So, welcome, Tess, to the Hello Therapy podcast. Thank you so much for joining me.
Oh, hi. Thank you for having me. It's my pleasure to be here.
So, we're going to talk about myths today around therapy, because I think there are a lot of myths, aren't there, around the sort of therapeutic experience. But can you first tell us who you are and what you do?
Sure. Yes. So I'm Dr. Tess Browne. I'm a chartered clinical psychologist and psychological coach. I work in private practice. I offer online services. So I work with people across the globe, mainly working with mums, anything from sort of maternal mental health related issues, trauma. I also do a lot of work with working mums in the corporate environment, so related to burnout and, managing all the things that we have to juggle between parenthood and work and all of those sorts of things. So that's kind of most of what I do. I do a bit of support for therapists in private practice as well, and then training and workshops as well as needed. So nice sort of range of things.
Just a few things there.
Yeah, keeps me busy.
So let's think about myths. When you think about myths around therapy, what for you as a therapist, as a psychologist, what's the first myth that sort of comes to mind for you?
Probably one which I hear time and time again in my clinic room is I don't deserve to be here, or I shouldn't be here. I'm not ill enough to be here. There seems to be this real assumption that one needs to be really unwell or really in crisis or have experienced some kind of really significant trauma in order to be deserving of therapy. I hear that a lot, and it's just not true.
Absolutely. And I think, we were both trained within the NHS, weren't we? So,
Yeah.
And I think NHS mental health services, a lot of the time you access them when you are towards the more severe and enduring end of things. There's a range of services now, but I think perhaps that perpetuates that idea that, you've got to be really, really bad until you see a therapist. But as you say, it's absolutely not true. And certainly in the world of private therapy, I don't know about your practice, but I see a whole range of presentations and problems and difficulties, and everyone is at, there's a whole range of how severe that is.
Yeah, absolutely. Absolutely. I think, absolutely. I think the sort of threshold in terms of accessing some of the NHS services are quite high, and rightly so, in terms of the people really needing the support, getting the support, and they obviously have a lot of demands on them, and we know there's a lot of wait lists and so forth. And that's one of the great advantages of accessing therapy through privately, is that there isn't that sort of threshold, there isn't that eligibility criteria as such. And certainly in my private practice, I will work with people across a real wide breadth of different types of problems, but also different severities of problems, including people who actually don't really identify as having any particular problems or particular struggles at all. They actually identify as doing, reasonably okay, but they would just want to learn some tools to stay okay, or to feel even better, to be even more resilient. And I think one of the fantastic things that I love about clinical psychology is so much of the information and so many techniques, so many strategies, so many tools can be as applicable to somebody who is in severe distress, to someone who is doing okay and wants to work on just bumping their resilience a little bit more. And actually, I feel like, I'm sure you'll agree with this, there's a limitation with therapy. When someone is severely unwell, that's not necessarily the right time for psychological therapy. That might be the time for another type of mental health intervention, like medication or some kind of supportive holding or counselling. Because therapy is often it can be quite demanding in terms of emotionally demanding, practically demanding. And when people are quite unwell, that's not necessarily the right time to be accessing therapy. It's often when they're feeling a little bit better that they're able to make better use of it. So it's always better if people do access therapy before they get to that stage.
I agree with that, and that's why in NHS services, certainly mental health teams, you have a multidisciplinary team of people, don't you, that can help a person, and that might not necessarily be the psychologist or the therapist in that team as out of the gate, and as you say, sometimes it's about somebody getting onto medication and reducing some of, say, the anxiety before they can really sit with a person and really think about their issues and their problems and start to work on them. And as you say, with private work, it's great, isn't it? Because you do get the full range of people coming to see you. Sometimes I see people who, just aren't sure about what the problem really is, but they know that there's something that's not quite right, and they're not sort of living their full life. And part of the work is about exploring, what that might be. So you do take a more exploratory approach and get to know the person. And then start thinking about goals and things. I think the way that I tend to work generally is somewhere in the first few sessions thinking about, what are we working towards? What do you want to change? What would it look like if we got to the end of therapy, and how what would your life look like? What would be different? Is that how you tend to work as well, or are you less goals based?
Yeah, I'm probably quite similar, thinking about the goals, and then sort of shaping our work around that, and the formulation or the hypothesis that we kind of form together, which sometimes those two things don't necessarily sort of add up, and so we might need to sort of shift the goals or tweak them a little bit. But I work in a very similar way, and I think people I work with find that quite helpful, because it then sort of gives them, they sort of know which direction they're heading. They know where they're aiming, even if that direction changes a little bit and the goalposts change. I think it can be quite containing for a person, especially if they are coming into therapy feeling very overwhelmed and feeling very confused about what's going on for them and not really understanding. These sort of little anchors, which I think goal setting can provide, one of those can be quite grounding.
So is our conclusion that therapy is not only for people who have very serious mental health problems?
Absolutely. I mean, I am a big believer that therapy can be helpful for anybody. As you know, I spent quite a lot of time working overseas in private practice. And so in doing that, I was exposed to people from many, many different countries, many, many different cultures. And what I found particularly interesting, especially with working with people from North America, actually, is their view of therapy felt very different to, I think, the typical British view of therapy. A lot of people that I met from America would go and see their therapist like they might go to see a personal trainer. It was just part of their health, self-care, process. And I see that more and more now here in Great Britain as well. But having worked, within that environment for a number of years, I really truly believe in the value of therapy, regardless of where your mental health is, be it good, be it poor, be it amazing. I think therapy has something that it can offer everyone.
It's so interesting you say that, Tess, because I have the same reflection. I probably haven't worked with as many Americans or Canadians as you have in my time, but I have the same experience of it feels like there's a different mindset over there. And I do think it's, as you said, I do think it's changing, but I think in the UK, therapy is a bit more stigmatized than perhaps it is overseas. And I think that can be a bit of a barrier, or at least it has in the past. Certainly in my, I don't know, 6 years of being in private practice, I have seen a shift actually. People seem to be much more open to trying therapy. But yeah, it's interesting, isn't it? The sort of cultural differences.
Yeah, I wonder if it's partly to do with the way the sort of the medical systems are set up, and obviously here we have the NHS, and typically one would access the NHS, be it for physical or mental health, when there is a difficulty, when there is a problem to address, and obviously things are done quite differently over in the States, and so I don't know if that has a bit of an angle, and I think certainly in recent years people in Britain are accessing not just private therapy, but private health services, probably increasingly as demands get higher on the NHS, if people want to be seen sooner for things which maybe don't meet the criteria for the NHS especially. So I think that is, as more and more people do access that, I think that's helping to break that stigma. There's still a long way to go for sure, but I do think there's definitely been a shift in recent years, I think.
Yeah. So let's move on then to another myth, and this is a myth that I have heard a lot over the years, and it's this idea that we as therapists have all of the answers, and that it's two-parter, that we have all the answers and that we give advice. So what do you think about that myth?
Well, I feel like if we had all the answers, people would probably just come and see us for one session, and then we wouldn't really see them again if we've imparted all those answers in that session. I sometimes wish we did, but no, we don't. And I think, and this relates to that sort of part too about giving advice, or telling a person what to do, even if we had the answers, or we suspect we have a hypothesis of what a solution might be for that person. It's absolutely not our role as a therapist to be telling somebody what they should do. Our role is to support somebody in gaining insight and understanding into their own mental health, into their emotions, into their thoughts, into their behaviors, so that they can feel empowered to make decisions about what the next step might be for them. And so it's I very much see it as my role as a therapist to support them in that journey, to maybe guide them, maybe nudge them in certain directions, especially if we're able to sort of see things from a perspective that they're not able to see yet or access. And obviously we're bringing all our expertise and sort of joining some of the dots in a way that they might not be able to do. But it's not our job to join those dots for them, but to maybe share some of our expertise in a way that they can do the joining of the dots, so they can make those decisions. And that's a much, much more empowering and long-lasting process, because it also means that they are then learning the tools or learning certain ways to think, which they can then repeat long after their therapeutic relationship has ended. If it's just about us imparting advice and telling a person what to do, I think that would really limit the value of therapy.
100%. And I think it also links in with this idea of psychologists or therapists being the expert, in inverted commas. We do have expertise, we have knowledge, we've done lots of training, and as a clinical psychologist, you've done research as well. So we do have a certain level of knowledge, and we bring that into the therapy. But as you say, it's about sort of using that to help guide someone towards their goals, and to help them understand particular aspects of their difficulties or their life at the moment. And I always say, or one of the things that I say to people is, I have expertise in this area, but I'm not the expert of you. You are the expert of you. And actually, this process is about a therapeutic relationship where we work as a team.
Yeah. I say exactly the same thing. It's about us bringing those expertise together, isn't it, and working on this collaboratively together. I think people like that because it most people who I see in therapy anyway, they don't just want the quote fix. They want to understand. They want to understand, why do I feel the way I do? What led me to feel the way I do? Partly to understand their current experience, but also that's useful for the future to help them navigate, similar obstacles and similar challenges. And so that collaborative piece is so important to enable them to do that. And I think that's what I feel like that's a real strength of clinical psychology, because as a clinical psychologist, I mean, I'm not trained in other types of psychological professions, obviously, but I know one of the real sort of unique strengths of a clinical psychologist is that we have these expertise in what we call formulation, essentially hypothesizing. And in simple terms, that's basically understanding the why. Why do I feel the way I do? Why do I act the way I do? What could have caused this in recent past, in for longer term past? What keeps the problems going? And that's so helpful for a person to understand that, and a really useful long-term skill for them to be able to do.
Yeah, absolutely. And I think it can be a bit tricky sometimes if people do come into therapy with that expectation of, this person's going to solve all the problems that I have, and I just need to tell them what the problem is, and then they will give me the answer. And I think part of the work I do with some clients is sort of managing those expectations and exploring with them, okay, so what is it that you are wanting from this process? And I always try and make a point of asking that at the beginning so that we can kind of start off with a shared view on how this is going to go. Do you do the same thing, or does it sort of naturally come?
Yeah, I absolutely do. And there's definitely variations in that. I know I've had experiences where I offer a type of therapy called EMDR, for example, eye movement desensitization and reprocessing, absolute mouthful. But I've had people come to me and they've said, oh, my mum had EMDR and it worked wonders for her, so I need you to give me some of that. Almost like it's like a drug that I can give them, like a medication I can give them. And unfortunately it just doesn't work like that. So yeah, definitely having that conversation about how therapy works and what might have worked for one person might not work, or might not be the most appropriate thing for another person, and just absolutely managing those expectations. I think that's really important from the outset, so that they understand that they have a responsibility to take a role in this, and also some agency in moving things forward.
Yeah, that's a really good point. Because there can be some people that go into therapy maybe not necessarily particularly willing to make changes. And I think sometimes that can be a little bit of a shock in the therapeutic process, this sort of idea, oh, actually, I need to take responsibility for this. And the things that we're talking about in therapy that might be helpful, i.e. changes in what I'm doing, or doing things differently, particularly when it's things like, if you're anxious and you're avoiding certain things because of your anxiety, like that's always a key one. You have to start changing some of that behavior in order to change the anxiety experience. And I think it can be a bit of trial and error in terms of, okay, let's try this, and I've got this tool and this strategy, and maybe go home and practice that. And it might help, it might not, but we need to sort of work that out. So that's for me, again, therapy is a trial and error process, and sort of helping if someone isn't particularly willing at the beginning, again, exploring that and exploring the reasons for the blocks.
Yeah, yeah. Especially if, I don't know if you've had this, but if somebody's come to see you because they've been sort of told they need to come and see a therapist by a family member or spouse, and so they're not really there of their own volition, and so they're not really bought into the experience and the work that they'll have to do. You know, therapy can be really hard work. And so just, yeah, I think it's important from the outset that people are aware of that and aware of what their role in this process is. It's not just about, it's not just about us clicking our fingers or waving that wand. Doesn't work like that.
Yeah. I wish I had a magic wand, but I don't.
Same.
But yeah. So let's move on to what are the other myths that we thought about. Going to therapy means that I am weak, or going to therapy means that I'm incapable of dealing with things on my own. Do you come across that idea?
I do. I come across it outside of the therapy room. Like, you hear that, don't you? You hear people make that assumption or that inference just through conversations, social media, the media, and so forth. And I find it really interesting because I feel like the complete opposite is true. Like, I feel like coming to therapy actually takes a lot of courage. Actually is a sign of real strength, not weakness. It's much more challenging to face your problems than to avoid and hide from them. And I can completely understand why people do that. But I think it's really important that we blast that myth, because I think it can be a real barrier to people accessing support. And you know, if they're not even stepping through that door or sending that email to make that first appointment, then obviously they're not going to benefit from any of the aspects of therapy. But yeah, I just see so much bravery, so much courage and resilience in the people who come into my virtual clinic room. Far from weakness.
Yeah. And I've been reflecting a lot on sort of generational differences, and I wondered whether that was part of this, in terms of, I guess, maybe older generations having this idea of like that stiff upper lip idea, and that you've got to just get on with things yourself. Whereas I think younger generations maybe don't have that same idea so strongly, would you say?
Yeah, absolutely. I think there's lots of different biases, isn't there? I think definitely in terms of, different generations. I mean, the younger generations are exposed to so much more normalizing information about accessing therapy now. It's very much normalized in the way that it just wouldn't have been for, say, our parents. And then I think you've also got the role of gender, you know, the messages that were stereotypically sort of drilled into boys versus girls in terms of like crying being a weakness and so forth. And I think there's a real shift in that. I hope there's a real shift in that, you know, for children now and for the way that we parent now. But obviously the impact of that is long-standing. And so for the older generation, especially maybe males, there really is going to be that that sense. And also culturally, again, I guess just sort of drawing from my experiences of working in Asia, some real strong cultural biases about what therapy means and what it would mean if someone was to access it. Yeah, yeah, very much still alive across the world. This sense of therapy and addressing one's emotions as being as a weakness.
And I think, again, thinking about that from that stigmatizing point of view, this idea that going to therapy, means you're deficient in some way, or it's you should feel ashamed that you're doing that in certain cultures, in certain circles, in certain generations. And I think you're right. I think it is definitely changing, but it's still there. And I know that there are lots of groups, particularly marginalised groups, that don't access or can't access therapy as easily as other groups. So I think there's still work to be done.
Yeah. Oh, yeah, absolutely. I remember not so long ago sitting down with a bunch of my psychology friends, and over the course of the afternoon, it kind of came out that each of us had been, accessing therapy, and we were like, "Why have we not been talking about this amongst ourselves?
Right.
This seems like utter madness." We've sort of been pulled into that stigma, even though we don't believe it professionally, and yet personally, it's still very much alive and there. And I do think that is starting to shift. I really do think, and I really hope that we will see, a change in that, and that will become less and less present in our dialogue over the next sort of like 20, 30 years.
And actually, that makes me think about a LinkedIn post that I saw. Was it yesterday? Where somebody, a qualified clinical psychologist, was talking about how, all trainee clinical psychologists should be in therapy, or should, be thinking about going into therapy themselves. And I think something like that always creates a lot of comments and a lot of engagement. But it's really interesting you say that about, with your psychology colleagues. Why is it that you're not talking to each other about your therapy experience? And maybe it's because in terms of our training, it's not a thing that is expected. Whereas a profession like counselling psychology, for example, you do. It's part of the training that you are in your own therapy. And maybe that's part of the reason why, as clinical psychologists, we perpetuate that myth, right? In terms of
it's interesting, isn't it, that different. And I think there's an assumption that as a therapist you have to be in therapy, and as you say, for some types of psychological practitioner that is the case, but it's not for clinical psychology, which is an interesting one, and I'm not really sure why that is. But I think there is a general feel of it's good practice to have
right.
sat on the other side of the couch, so to speak. And I think increasingly it is now the norm. But yeah, we could, as a profession, we could do better in terms of talking and normalizing that, I think.
Definitely. Which is part of why we're here on the podcast, talking about it.
Yeah.
Okay, so moving on then to another myth. So let's think about this myth around you'll be pressured to talk about traumatic experiences. So I think that there can be there is a lot of anxiety, isn't there? If you haven't been to therapy before and you have made that decision to go to therapy, I think one of the worries that can come up for people is, I'm going to be forced to talk about things that I don't want to talk about, but particularly traumatic experiences or traumatic childhood experiences. Have you come across that in your practice? Have people said that to you?
Yeah, they've either said it or it's been kind of clear from the way that they presented that they are afraid of that, and it's an obstacle that we need to address. And I think there's a couple of ways of looking at this. I mean, I think firstly, you will never be forced to talk about anything. This is not about a therapist forcing you to be in any position or talk about anything that you don't want to talk about. Our role is to create a safe space where, should a person choose to talk about certain topics, they feel that if they do and how they do is going to be met and held safely, and it's going to be done in a way that they feel contained, they don't feel too overwhelmed. And I think, what that looks like is so different for every person, because, as you'll know, it's not the event per se that makes talking about something challenging. It's what that event means to a person, and what something means to a person is going to be so different and unique to every single individual. One of my clinical specialisms is working in trauma. And so, I've worked with people who in that first session, they've been itching to get something off their chest, and they really want to share it. Like, that's really, really very, very important for them right from the outset, which is absolutely fine. And I've worked with other people who have actually felt never able to talk about certain things. And I think what might be useful for your listeners to know is that there are some therapeutic techniques out there which can help you to process a trauma, which don't actually involve you having to talk about the trauma or in any detail, let alone a lot of detail. So I mentioned EMDR earlier, but that's one of the therapeutic techniques that can facilitate the processing of a trauma without going into the details. Now, obviously, as a therapist, it's helpful for us to know as much information as we can know, so that we can give you the best supportive care that we can give you. But a lot of people just aren't ready to share those things, and that's fine as well. Absolutely shouldn't be an obstacle to them coming and accessing support. I think it's really important that people know that they can still have support in processing and coming to terms with something without having to go into all the details, if that's something that they want to do.
Yeah. And it also makes me think about my specialism with working with people with OCD, and often a barrier can be, if I go into therapy for my OCD, I'm going to have to stop doing the things, the compulsions that keep me safe. So sometimes, a lot of the time, we have to do quite a lot of work around those beliefs and ideas. And as you say, that really giving that sense of, I'm not going to force you to do anything that you do not want to do, but I can put forward ideas about how I think things might improve for you if you did X, Y, Z. And certainly when there's a lot of anxiety, or it's an OCD picture, doing some kind of hierarchy where we think about, okay, what's the least anxiety provoking thing that we could start with, and then we can work our way up to the most anxiety provoking thing in terms of not doing the compulsion around that particular situation. But with trauma, it's a bit different, isn't it? Because there are therapies where you do go through a talk about the trauma in a lot of detail many times over. But I think personally, I think that's why EMDR is so popular, because you don't have to do that, and it's shown to be effective.
Yeah. And for some people, it's really important to them to talk about things that they experience in a lot of detail. And that's why, at the outset, when we're doing our clinical assessment and we're starting to understand the problem, we're also thinking about what's important for you from this process, so that we can think about which approach would be most appropriate for the individual that's sat in front of us, rather than be prescriptive. I think it's also important to just acknowledge that as a therapist, we have to walk a little bit of a fine line between sort of colluding with avoidance of talking about something, because often, and I'm sure you've had this, I'll be sat with somebody and we can feel a little bit stuck in the therapy process, and there's kind of this elephant in the room that's not been addressed, that's not been talked about, or that's been consistently avoided. And actually, in order for us to move things forward, it might be really important for us to address that obstacle. But as
Yeah.
you say, we can do that in a really systematic way. We can create a kind of a bit of a hierarchy of what what feels manageable at
Hmm.
this point, and then what do you feel comfortable sharing? We can build on that later.
Yeah.
As you say, we're always working in collaboration with our clients, so we're always doing it at your pace. You're always in the driving
Mm.
seat.
Mm. That's so important to highlight, isn't it? Because like we've been talking about earlier, that idea of like the expert therapist, and you're going to their office or you're on Zoom or whatever it is, and that power imbalance, or it can feel like there's a power imbalance. And I think as psychologists, I think we're very aware of that power imbalance, and I think we work very hard to help someone feel like, as I said, like we're a team and we're in this together. And also, I think we're talking about very difficult things. Yes, some people might come into that first session and sort of really just need to get it out, and that's fine. Other people can take a long time to get to the point where they feel comfortable sharing something that is incredibly difficult.
Yeah.
And that's why that therapeutic relationship, building that rapport, giving that sense of warmth and safety is so, so important. And having that patience as a therapist as well, I think, to carry that client along to a point where they can, divulge or disclose what it is that's happened to them.
And there might be certain emotional obstacles that we need to work through. So I guess we've sort of alluded to fear a lot in our conversation, but also feelings of guilt, or certainly feelings of shame.
Yeah.
Shame is a big one, which stops people from talking. And we know that silence is like pouring petrol on a fire of shame. It just keeps it burning and burning and burning. And so if we can break that silence and start unpicking and sharing a little bit about the thing which we're holding back, I mean, it's often quite remarkable how quickly, when a person starts talking about something that they might have held privately for so many years and have been so afraid and so ashamed of talking about it. I've had so many clients say how much better they feel just from having shared something, and been so surprised at how quickly that has had an impact. Talking can be so powerful.
Yeah, because as you say, for some people, they haven't told anyone ever. And certainly when I worked in the NHS working with older people over 65 in that particular service, sometimes it was decades and decades that somebody had not said this thing to anyone, and they'd sort of carried this along their life. And the power of really finally being able to say it out loud even was therapeutic, cathartic in itself. But having that relationship as like a frame, to hold that, and I always feel completely honored and privileged to be in a position where I can hear those stories and hopefully help someone through that memory, through that experience.
Absolutely. Yeah, it's a real privilege, the work we do, isn't it?
So let's think about our last, I'm just looking at time, our last myth, which we were thinking about social media. So social media can replace therapy. So that is a myth that I've come across. And well, I think social media these days, it's a whole I mean, we could spend a whole podcast talking about social media and therapy. What kind of things have you come across within this sphere of things?
Oh, it's a minefield, isn't it? Well, I hope social media isn't going to replace therapy, or we'll all be out of a job. I mean, I think there is a lot of incredibly valuable, useful, and helpful content out there on the various social media platforms. I really do. And I think social media provides a fantastic, accessible way for people to access some of this mental health information, and strategies and tools, for free, which without social media they just wouldn't be able to see. I think it plays a huge role in normalizing mental health and normalizing going to therapy, as we were saying earlier. I think it can be incredibly valuable, and for that I'm very grateful. However, I do think there are also aspects of it which are less so. There is definitely a lot of inaccurate, actually quite harmful information out there regarding mental health and the treatment of mental health on social media. And that's not helpful. So I think it's important as a consumer of social media that we are doing our due diligence in terms of asking ourselves who is providing this content. What's their experience or expertise in sharing this content, and what can I take from it? And I think there's really value. I really think there's value in hearing from people who've had lived experience of mental health. I think there's real value in hearing of people who are experts, professional experts in mental health. But no, I definitely don't think it can replace therapy. I think it can be a great adjunct to therapy. And I think it can give people sometimes a bit of a head start, so to speak, with therapy, because they're kind of coming into therapy probably being a lot more knowledgeable about various aspects of their own mental health or psychological concepts that they otherwise wouldn't be.
Yeah. And I think that's a great point in terms of due diligence. And I think certainly, I think most people do their due diligence, but I worry about sort of younger people, teenagers, sometimes very young teenagers, who are on social media and are consuming content that is inaccurate. And in fact, there's quite a few research studies now that show the inaccuracies in social media videos, particularly TikTok, and that there can be a lot of misinformation. But you're right. I think it's so valuable to hear someone who has lived through a particular mental health problem and is sharing what helped them. But that is very different to being in a therapeutic process with a therapist, where that therapist is trying to understand your specific difficulties and how they've come about. As you say, as a psychologist, we work very hard on formulation, that building a picture of someone's difficulties and how they've come to be. And you don't get that on social media. You know, you get, oh, here's PTSD and these are the symptoms. There's no nuance in social media. You can only really get that through being in therapy and sharing your story that way.
Yeah, absolutely. And I think one of the risks of it, and I hear this a lot actually in the therapy room, is sort of people coming with, they've sort of self-diagnosed, they've got this disorder or this condition. And, you know, as a clinician who's trained in diagnosis, you know, we can quite quickly dispel some of those inaccuracies if that's indeed what they are. And I think that can be so important, because often people will have been sort of sat with this belief that they have a certain thing or they are a certain way for a long time, and it's just not accurate. It's definitely an area which, I think is just going to grow and grow and grow. It's not going anywhere. I will say, and I'm sure that you would say the same, that when I think back, I've been working in mental health now for, over 20 years. And I really remember a certain time point when Facebook came around. It was actually before Instagram, but the comparison, that comparing just became so much more of a prominent feature of someone's mental health difficulty than it had been before social media was around. So social media has a huge role when it comes to mental health, massively. And I think some very helpful aspects, but we have to be cautious.
Yeah, and I was just thinking there that somebody sharing their, say they've seen a video of someone and it's really resonated. So it's someone that's not a mental health professional, but somebody who is sharing, this is my story and this is what helped me. And then that person looking at that video, puts a comment on saying, oh, me too, and I've experienced this and this. The thing about that is not confidential. You are putting that out into the world. And I think that's one of the features between therapy and social media, is that obviously in therapy, what you are saying in that room or on that Zoom call or whatever is confidential. That isn't for the world to hear. But when you put that stuff on social media, it is out there. And whilst you may feel comfortable sharing that stuff at that point in time, that might change in the future. So I think that's the other thing, isn't it, about I guess the caveat to this is, just being aware that when you do, if you're doing a video or you're sharing your thoughts in the comments section, that it's out there for everyone to see.
Forever. Yeah.
Forever. Yeah.
It's always a trace. Absolutely.
Yeah. Would you say that there's any other differences between therapy and using social media for mental health information or education?
I think the point you made earlier about it being general and not person specific is really important. What is accurate for one person might not be accurate for the next, or works for one person might not work for the next. So just being mindful that it might not be applicable to you, being mindful that it could be completely wrong. But being curious. I think if people see things through social media and it sparks something and they think, this feels relevant to me, this feels something which I might relate to, that might then be the beginning of their journey to think about, maybe some kind of mental health intervention, maybe working with a therapist would help me to understand that better. So I think it's about being curious, asking yourself the questions, and not just assuming what I see is how it is. What I read is how it is, because it's not always.
And I think what I would add to that is, if you are someone that is following therapists or psychologists on social media, I guess also bearing in mind that that person isn't your therapist. So they are a therapist, but they're not your therapist. And therefore, as you say, the information that they're giving on social media isn't individualized. It's always going to be quite general and not specific to you and your circumstances and your experiences.
Yeah, absolutely. And no therapist should, and hopefully is not, but should not be giving out any kind of advice over social media. I think most professionals or clinical psychologists like you and I who use social media through our work, we'll make it very clear, we'll have some kind of disclaimers sort of saying that this is not therapy, this is not a substitute for therapy, I'm not your therapist, and just really being clear on that boundary and communicating that boundary to people. I think most people understand that, but sometimes there can be a little bit of confusion with that. Don't let something that you have heard or been led to believe or seen on social media or in the media, don't let that be an obstacle to you accessing therapy. I think there is a space in therapy for everybody. And if you're even curious that it could be something that could help you, at the very least, have a conversation with a qualified mental health professional to see if it could be something that's helpful for you. Don't let a myth or an assumption or a rumor stand in your way to exploring that.
Yeah, that's great advice. Thank you so much for your time today, Tess. I really appreciate it.
Oh, you're so welcome. I really enjoyed the conversation. Thank you for having me.